All right, so it's a great pleasure for me to introduce Dr. Eva Herbst. So Dr. Herbst is currently a postdoctoral fellow at ETH, and she's working at also at the Shirtless Clinic. Hopefully I didn't mispronounce it too much. And previously she was a PhD student at the Royal Veterinary College. She worked with John Hutchinson. Previously was a student also at UC Berkeley. And she's done a lot of interesting work in computational modeling, but in general kinematic analysis and biomechanical models. And today I believe she's going to talk about the shoulders. And without stealing too much of her time, very happy to let her talk.
Thank you so much for the opportunity to present today. So let's see if this works. Yes, so as you already gave a quick overview, I'll just zoom through the slide. So as you said, I have more of a background in comparative biomechanics and paleontology, which is what I worked on for during my PhD and my postdoc, my first postdoc. But then for this current project, I'm moving more towards clinical shoulder biomechanics. But what relates all of these projects is investigating the links between form and function, and also the development of new simulation methods so we can better characterize specific joint kinematics and the effect of joint loading. So firstly, I wanted to give a brief clinical overview of the aims of my project. So we want to tackle various clinical challenges, but one of the really main challenges we face in shoulder replacement surgeries is this concept of glenoid component loosening. So in anatomic shoulder replacements, the glenoid component is eccentrically loaded by the humeral head, which is called the rocking horse phenomenon. And this is thought to lead to implant loosening. And to give you an idea of the extensive nature of this problem, my clinical boss once said, it's not a matter of in how many people it loosens, it's a matter of when it loosens, because it always loosens eventually. And this is really problematic because these anatomical joint replacements, when they work well, have fantastic capability of reducing pain and restoring joint mobility. But when they fail, it's very problematic because any sort of shoulder revision surgery, then you have even less and less bone to fixate these components. So it gets worse and worse and worse. Just a side note, we also have reverse total shoulder arthroplasty, where the ball and sockets is reversed, which is more stable, but then we don't have as much functional mobility. So this is just to give a clinical context for why we're so interested in making physiologically realistic biomechanical simulation models that take into account patient-specific anatomy. Although this talk specifically won't focus on implant development, it focuses more on the groundwork of understanding what the healthy glenohumeral joint looks like and how to implement this in the simulations. So the overall research aims of my fellowship are to develop biomechanical shoulder models combining finite element analysis and multibody dynamics, so muscle-driven simulations, then incorporating subject-specific anatomical factors into these models, and then applying them to various challenges such as this implant loosening problem. So to give a brief overview of the glenohumeral joint, if we compare it to something like the hip joint, this joint is very shallow. There's not a lot of enclosure of by the glenoid of the humeral head, as you can see here. And this facilitates a lot of mobility, but you can imagine that there's also not as much stability as in a joint such as the hip, which we need to keep in mind when we're thinking about how we model this from a simulation side, and also in terms of the challenges that pathological subjects might face in terms of joint instability. And to give an overview of the variation that we have in this joint, so we have variation in that concavity that I was talking about. So the glenoid in some subjects is even flatter than in others. We also have extensive variation in, for example, the curvature of the scapular blade, the acromion, which is an important muscle attachment site. And this is just from a population of healthy subjects. So you can imagine in pathological subjects, this variability is even more extreme. You get extreme osteoarthritis cases where the humeral head flattens. You have cases of lesions that might engage on the glenoid rim and essentially get stuck. So these are all things that we want to incorporate into our models. And that's just from the static anatomy, but also we know that scapulothoracic posture can influence clinical outcomes and range of motion. We know that scapulohumeral rhythm, so the rotation of the scapular blade on the thorax versus the rotation of the humerus relative to the scapula to produce arm elevation, varies between subjects, and that can also impact joint forces. And as I mentioned, the joint anatomy itself can influence how much stability there is. So for this talk, I have 2 research questions I want to focus on. First of all, the first question is, how does the anatomical variation affect the kinematics and stability in the glenohumeral joint? And then the next question is, how can we better model the glenohumeral joint and surrounding muscles to capture patient-specific variability? So for this study, we wanted to investigate in vivo glenohumeral translations, both in terms of magnitude and pattern. And then we wanted to see whether various parameters affected these translations. So first of all, motion. So that's 3 different arm raising motions, as well as external and internal rotation movements, whether we were adding a handheld load or not, the patient posture, and then various joint geometric parameters. And I want to point out that these were all measured from the bone surfaces, not the cartilage surfaces. So these include glenoid inclination and retroversion angles, which I'll get to a few slides from now, the sphericity of the glenoid and humeral head, and then also the radial mismatch between the glenoid and humeral head. So we measured 19 healthy subjects throughout these 8 motions, and then 3 of those motions, the arm raising motions, also had added weight. We define glenohumeral translations as the translation of the center of the humeral head, which was defined as the center of a sphere fit to the articular surface, relative to the glenoid axes. And there have been some studies that compared the helical axes to a sphere fit to the humeral head center to see whether this accurately represents the rotation center. And this does seem to be a good representation. It's much easier to measure consistently in studies because we're defining it based on the anatomy. Then we created a linear mixed effects model, and the goal for this is to really account for all possible combinations of effects in all of these geometric parameters, as well as motion. We also included glenoid height because we thought, maybe we just have different translations in different subjects because some subjects are bigger, some subjects are smaller. And we also included subject as a random factor because some subjects might just have different baselines. And then we can really investigate the combinations of all of these parameters. So previous studies have investigated glenohumeral translations, but they usually don't report subject-specific variability, and they don't usually report the combinations of all of these parameters, which have all been suggested in the literature that they could influence the translations. But we wanted to control for each one to see which ones were actual possible predictors of the glenohumeral translations. And then here quickly on the right, you can see how we define the inclination angle and retroversion. So you can think of the inclination angle as essentially how tilted the glenoid is to the superior. And then the retroversion is how posterior the glenoid is tilted relative to always a scapular coordinate system. So here are all of the results. In the panels, you see each separate motion with all the subjects pooled. So overall, we see translations of 5 millimeters. And then if we normalize that to glenoid height, so we can compare more easily between subjects, that's about 15% of glenoid height, but we have quite a range. And you can already see the range in both the variation and pattern in these pooled plots. There was a statistical effect of motion, but of motion type on the translations, especially high external rotation, so that's ERA 90, which is consistently lower than the other motions, especially for forward elevation, so that's the FE motion. And there was no influence of handheld load on the translations. But now if we plot the subject specifically, we see that actually these trends of which motion produces the most translations vary a lot between the subjects. So even though there's statistical significance, this is not consistent between subjects, and it's also not just one outlier, which indicates that these general patterns, these mean trends, so to speak, don't represent each subject. And the only case where this kind of order of which motion type had more translations was true for all subjects was really in the forward flexion versus the high external rotation. We also found no influence of posture and any of the bony anatomical parameters that we expected to capture the joint stability. And glenoid height did influence translations, which might be a simple scaling effect. So the effect size is we have, for 1% increase in translations, we have 1.5% increase in absolute translations, which seems like quite a different, it seems like not a completely linear scaling, but then the confidence interval is quite high. We have a low sample size. So I think it could still be a simple scaling effect, especially that if we then create a new mixed effects model and actually have the outcome instead of just translations in absolute terms with height as a factor that's controlled for, if we actually normalize the output term to translations as percent glenoid height, the glenoid height is not significant anymore. So this does suggest that this is a simple scaling effect, and this is to be considered in future studies. So not just reporting the absolute translations, but normalizing to subject-specific joint sizes, I think is quite important for data sharing. In terms of the directionality, we also investigate all of the parameters, but I'm just going to focus on scapular tilt now because the rationale of why we think that might change the directionality of the translations, I think, is the most apparent example. So if you imagine someone that has a more forward tilted scapula, and you can imagine everything else being equal, you could expect kind of a counterclockwise change in the patterns with increased tilt of the scapula. And here we sorted all of the subjects by scapular tilt, and we don't see any sort of consistent pattern here whatsoever. And this was also true for all of the other metrics we investigated. The reason we did this qualitatively is because we didn't want to kind of arbitrarily draw certain boundaries, for example, the quadrants of the glenoid, and we thought this would be a good insight if there was a clear pattern, which we have not seen. I think the most interesting outcome of this study is that we do see very subject-specific translation patterns and magnitude, and we couldn't account for it with any of the factors we measured, but I think it's really important to consider this in everything from if you're comparing different treatments or if you're implementing glenohumeral translations in your simulations or even validating your simulation data against published data sets, because there's not just one characteristic humeral translation pattern. So previous studies have suggested that generally the humeral head translates up and then down, but that doesn't seem to be the case for the majority of subjects, really. They're really all over the place. And we can see this a bit better when we zoom in. These patterns are completely different for the different subjects. And I would expect there to be even more variability in pathological subjects. Now you might say, okay, biplanar fluoroscopy is great. It's the highest accuracy method that we have to measure these translations. But how do we know that these patterns are actually subject specific and not just kind of small errors or differences in our registration of the image of the 3D models to the biplane images? And we did not repeat any motion trials for these subjects because already a lot of motions were investigated. And so due to radiation concerns, it wasn't feasible to also do multiple trials for motion. But what we then looked at was comparing similar motions. So we can compare, for example, coronal abduction and scapular plane abduction, which are quite similar motions, and see if these patterns stay the same within the subject. And this is actually what we found. So if we have here in each column is a different subject, and then in green is the coronal abduction, and in blue is the scapular abduction. And we do see consistent subject-specific patterns in the glenohumeral translations, which I find very interesting and is also very encouraging in the capacity of biplane to detect these subject-specific patterns. Because if they were just an arbitrary kind of registration errors, we wouldn't see this consistency within each subject between motion trials. So I found this quite interesting and encouraging for general measurement of these translations. So the conclusion of this study is that the glenohumeral joint has a relatively stable core. So by that we mean the core of the humeral head. And I say relatively stable because I showed these results to my clinical boss and he said, wow, that's really stable. And then my engineering boss said, wow, it really translates that much. So I think it really depends who you're talking to. But I think it's very important to keep this in mind, that not just the magnitude, but also the pattern varies between subjects. And this can be affected by motion, but again, a lot of these patterns that were statistically significant still did not hold true for many of the subjects. And we couldn't find any sort of influence of any of the bony joint parameters or posture that we measured. But we need to note that we didn't characterize the joint anatomy based on the soft tissues. And we know that the cartilage and labrum actually decrease the glenoid radius of curvature, and the labrum changes the inclination angle of the glenoid. So these future studies should incorporate these soft tissue parameters, which will also influence the joint stability or have the capacity to. Additionally, although we tested posture, we didn't test the relationship of the glenoid relative to the rest of the scapula, as well as any other scapular parameters that could then influence muscle line of action. So there are many different parameters that are still to be investigated, including also muscle activation differences that can then contribute to this patient-specific variability. So to move on to our next question, how can we model the glenohumeral joint and muscles?
Do you mind if I ask you a question now about this study? Did you check what's the effect of the age? And the other thing is, did you check if were there people which were left-handed or right-handed included in the study?
Yes. Good point. Yes. So in the terms of the effect of age, we did not investigate this. We have the data and we could also include it in the model. One of my students had run an analysis, and we did find that, interestingly, age seemed to impact the joint size. So glenoid height seemed to correlate with age, which was interesting. And it seems like maybe this is even early. I don't know. I can't definitely call it early onset or osteoarthritis, but also speaking to the clinician, as subjects get older, it seems like their joints get a bit flatter, and then you get some bone growth around the perimeter, and the joint also just looks different. So that is definitely one parameter that we should investigate. And I know these were all right shoulders, but that's a very good point about the handedness, and I did not investigate that, but that's also something that we could investigate. Yes, thank you. Yeah, I guess this is a good opportunity if anyone has questions on this specific study. Maybe now is a good time before I go into the simulation work. Yeah, does anyone have any questions? All good? Okay.
Thanks,
Right.
Eva. I have a question.
Mm-hmm.
And it's if you have any specific range for the motion of the translation, I mean, in which range it is usually for all of these subjects that you studied?
What do you mean?
The range of the translation, is it in order of 1 millimeter or 10 millimeter or?
Like the overall range, yeah. So I think you mean like the one that translated the least and the most?
Exactly.
Or,
I mean, among
yeah,
all of the subjects, how much was?
Sorry. So 6 in percentage, 6.4 to 31.6, and then in absolute up to 11 millimeters. And you can also see it a bit kind of in terms of hopefully these aren't too faint, but you can see like in some subjects it's really small, and some you really see the traces in the non-zoomed, and then here in the zoomed you can see in some, again, this is percent glenoid height, but it's very, very minimal in some subjects and quite large in a few of them.
Mm-hmm. And how much was the minimum? Roundabout 0.1 or?
I think that was, 2 millimeters was the minimum. But this is also in 3D excursion throughout the whole movement.
Okay.
So there's kind of different ways of characterizing, right? You can also characterize relative to the starting point, or we just did the entire, just how much it moves overall, because we also thought from the simulation side, it's interesting to know, really how much does the center of it, how much does it translate? Like, can we model as a ball and socket or not? Which is something I'll get into. Yeah.
Thanks. And about the mediolateral translation, have you also studied this, and was that possible?
Yes. So these are the 3D translations. So they also included mediolateral translations, and we did see mediolateral translations. I can check really quickly of what they were. They were similar to one of the other studies. Most studies don't analyze them, but we found a range of 0.5 to 5.4, which was actually more than I expected in absolute terms in millimeters. Yeah.
Great. Thanks.
So there is also a question in the...
Yeah.
Sorry. There is also a question in the chat. Hi, Eva, great talk. Sorry, I might have missed this, but how did you measure the translation? Was it with the centroid of the humeral head? This is by Erin Lee.
Yes, thank you. So yeah, I think I just mentioned it too quickly. So we isolated the humeral head region where we thought the cartilage would attach. We don't have imaging data for these, just the bone models, so which is also why we couldn't include the cartilage in any of the measurements. But we isolated that region and then fit a sphere to that and then analyzed the sphere center. Yeah. But then we're also now looking into analyzing the center of pressure. So, you kind of have two things. Like, it's interesting to see how stable it is from a translation perspective of the centroid of the humeral head. But in terms of joint loading, we also want to see, how variable is the center of pressure on the actual joint. And that'll also be affected, of course, by the geometry and the sphericity of the humeral head, presumably. So that's the next thing that we're looking into with this data set, because I think both are relevant insights into how the joint is functioning and what might affect variation.
Yeah, thanks so much, Eva. Sorry, I'm here with no video on at the moment. It's Erin Lee. Hi.
Hi, thanks for joining. Thanks for your question.
Yeah, no, thanks for sharing everything. I am just wondering because the translations are so tricky, because I guess if your centroid that you're measuring from the geometry isn't exactly the center of rotation, then it could appear like a translation, if that makes sense. So I just wonder how you might counter this when you get into the diseased bones where their joints are going to become less and less spherical, I guess.
Yeah, that's a really good point. I think for the healthy, I also thought about this, and I looked at, so these, obviously the 2D images are just projected into the glenoid plane, but I also traced them in 3D, and I was thinking, okay, if I'm getting a very weird, curved line, right, then that probably just means that my rotation center is just off. But I didn't see any clear patterns like that. But of course, you're correct that especially in the pathological subjects, it gets really, how, first of all, even defining the center gets more complicated. And then, it might just, I think there it probably makes sense to do some sort of instantaneous helical axis analysis and then maybe try to see, okay, are there any anatomical landmarks that best approximate this? Because I know this has been done for the healthy joint, and there the kind of spherical center seems to be a good approximation. But again, if you have one subject that's just doing something really strange, then that might not hold true anymore either. But yeah, that's a really good question. Thank you.
That all makes a lot of sense. Thanks, Eva. And thanks for sharing all this really beautiful data too.
Thank you.
Sorry, Eva.
There's one more question.
Mentioning the center of pressure, I wanted to ask if you have seen any correlation between the pattern of center of pressure and the translation.
Yes, my master's student is working on finishing up that analysis right now. So hopefully we have some data of that soon. I think the center of pressure was more difficult because then we have to at least estimate the cartilage, and we've been trying to also look at the effect of having constant cartilage thickness, varied cartilage thickness. So, and then, your smoothing algorithms start playing a role because the ground truth data or the models that were shared were very low resolution. So we're still working on that. And we haven't finished that analysis yet, but that is one thing that I'm very interested in also, is if there's any sort of correlation or not.
Okay. Great, thanks. I'm keeping an eye on the results that you publish, but I compared them for the anatomical prosthesis, not for the native joint, and they are, say, to a great extent, similar to each other, but with a different scale. I mean, the translations are in the order of 1 millimeter, but the center of pressure is in the order of, I don't know, 5, 6 I don't have the exact number in mind, but the pattern was exactly the same for the anatomical case.
Ah, very cool.
Yeah, I'm
That's
interested
super
to see if
interesting.
you
We have biplane
also
data
observe
from
the
that.
same, yeah, the
Do you
same
have
result.
biplane data from this or for the
No,
MT
no, just simulations.
simulations? Okay,
Okay, thanks.
thank you. All right, so we can move on to the next section. Right, so focusing now more on the simulation side of things. I think there's a few takeaways that kind of link the in vivo work to the simulation. So first of all, I think the subject specificity should really be accounted for. And of course, we also need to see, what impact would this have in pathological populations, because that's really relevant for the implant development. But I think in general, it's very good to be aware of this variability also for model validation, because as I briefly mentioned before, maybe your model just translates posteriorly instead of superiorly, and you're comparing it against general in vivo data. That doesn't necessarily mean your model is wrong, because you might have different patient anatomy, and I think that's very important to keep in mind. And we need more studies investigating the downstream effect on things like joint loading, bone stresses due to these different translations. So now, moving towards the simulation of the glenohumeral joint, one question might be, okay, can we just use these translational bounds from the in vivo data for our joint limits in the simulations? And anyway, what do I even mean by joint limits? So I think I'll just give a brief overview of this. Most of you probably are familiar with it, but I think it's still good to take a little step back. So in simulation joints, you can have limits or reduced degrees of freedom. So for example, you might just model rotations instead of rotations and translations to capture passive bounds. So this is really, instead of modeling things like collisions and ligamentous constraints, because modeling all of those soft tissues, and it's incredibly time intensive. So both in creating the models, in running the simulations, and we have uncertainty in material properties. So there will always be some uncertainty regardless of how detailed you make your soft tissue collision models. So the way we can simplify this is by making joint limits. So we can basically say, for example, okay, we know from observations from in vivo data or cadaveric data that I can internally rotate my humerus only up to a certain point, and then it goes no further. And instead of having to model all of the reasons why that happens, if that's not the main goal of our study, to investigate why that is, we can just say, okay, rotational joint limit is there, or it doesn't translate at all. We're just putting in translational limits, so we only allow rotation. So that's kind of the rationale behind having these joint limits. But this is a balancing act, because if you restrict the range of motion too much, especially if you're simulating muscular activity, we're introducing false stability that in reality should either be taken over by the muscles, or in reality, maybe with a given joint configuration, muscle activation, you might actually get subluxation, and then your model is telling you it's fine because it has these artificial joint constraints in it. But then if we don't constrain it enough, your simulation becomes unstable, and then you're basically not modeling the passive constraints that are actually there in vivo. So it's very difficult to strike this balance in terms of how much do we constrain or limit these joints. And in healthy subjects, especially for the glenohumeral joint, this is difficult because we know that this is achieved, the stability or the relative stability of the glenohumeral joint is achieved in a large part by active muscular activity. So going back to the glenohumeral joint anatomy, I mentioned that the cartilage and also the labrum change the joint surfaces and make them more congruent. But then there's still a lot of range of motion, as you can see here, if we look at the cartilage and labrum. And then we have the ligaments and capsule, although the ligaments are thought to be mostly stabilizing at the end ranges of motion. And then we have the muscles. So the rotator cuff muscles are really pulling the humeral head into the glenoid and something called concavity compression and stabilizing it. Okay, so how do we know that the stability is really coming from the muscles and not, say the ligaments? Well, we have these functional instability subjects that have no consistent structural deficiencies in the joint. And at specific locations, this can be either deliberate, so they can produce a subluxation, or it just happens at specific positions, but you can see the humeral head completely essentially pops out of the socket. And this tells us that really the passive bounds are quite large under certain combinations of, yes, pathological, but still biologically feasible muscle combinations. And what's very interesting in these cases is that a pacemaker that selectively activates certain muscles that are underactivated can then restore the stability. So I think this is really important to keep in mind for our models, that our models should have such large passive bounds. And we also want the models to be able to replicate this instability. You know, if in our model we activate the muscles such as this patient would activate, we do want to know whether that would sublux the humeral head or not. However, although this has changed in recent years, traditionally the glenohumeral joint has been modeled as a ball and socket joint, and it still is in many simulation models. And this prevents the translation, so you just have 3 rotational degrees of freedom, and we're therefore, as I said, not able to assess the joint stability, and we also underestimate the activity of the rotator cuff muscles, because essentially the simulation joint is providing stability that the muscles should be providing. So I made a little simulation here that essentially shows what is happening in this virtual simulation joint. So here we're preventing translations, and the red arrow is the force, the translational force that would be applied. So the humeral head wants to go in that direction. And the simulation joint, because no translations are allowed, is providing an equal and opposite force, which is the yellow vector. Now, in reality, if this force was pointing into the joint, you could say, okay, well, that's reasonable. You know, it's just any sort of collision force that would occur there. But you can see these arrows are not always pointing into the glenohumeral joint. Again, this is just kind of a toy demo, but I think it illustrates this concept that these simulation joints can apply stabilizing forces in any direction, and those vectors are not necessarily physiologically realistic. So we have a more limited stability regime, I would say, if we're just looking at collisions and muscle forces and passive forces, for example, by ligaments, versus the simulation joint, which can really apply forces in any direction at once to achieve the stability. So because of this, we're also getting underestimation of the rotator cuff muscles. So here the deltoid is doing most of the work, and it's stabilized just by the simulation joint, where in reality the rotator cuff muscles should be pulling the joint into the socket to stabilize against the action of the deltoid. So several solutions to better model the active muscle concavity compression have been proposed. There's something called the glenohumeral constraint cone. So we basically say, as I mentioned before, that all of these forces need to point into the glenoid, because if they pointed out, the humeral head would sublux. The problem is there, it doesn't work for subjects where the subluxation actually occurs, but it's kind of a way to mimic the neuromuscular control that ensures that the humeral head is centered. And we're also not really sure how much of this is a learned versus a feedback behavior, but it does seem to have at least a good amount of learned behavior associated with the glenohumeral stability. And sometimes people even activate the rotator cuff from EMG studies before actually performing an arm raising motion. But that's kind of the, I guess, biological concept behind this, and that these forces would then be where the muscles pull into the joint, and then there's the joint reaction force there. And if they were to pull outside of that cone, then that would cause subluxation. That wouldn't be a normal stabilized joint. But then these models are just limited to the normal joints, or the healthy joints. There's also a similar method that's based on cadaveric experiments of stability ratios. So looking at the translational force that the joint can withstand given a specific compressive force. And that also varies in the different directions. But the problem there is that it doesn't really take into account patient specificity. And these stability ratios might also change as you get different orientations of the glenohumeral joint throughout the movement. So our goal was to develop a new model that has active muscle-driven glenohumeral stability without any restrictive constraints on the translations. So we put very, very large bounds to mimic the passive translations. And by large, I mean essentially what we were seeing in that biplane video earlier of the patient subluxing the humeral head. So the center was really able to go all the way to the glenoid rim. And we implemented this in RDSynth with a frame spring with translational deadband. So that basically means it's able to translate without any resistance within the glenoid cavity. And then once it approaches the rim, then we apply the forces. And we also looked at some cadaver literature, and we've conducted a cadaver experiment to basically confirm that these bounds are reasonable in terms of the passive constraints. And then for the cartilage itself, we do model that as a collision-based, contact-based collision. We generated these cartilage layers semi-automatically to make sure that we also have varying cartilage thickness and that the cartilage surface geometry represents the bony geometry of that subject. In the future, we want to also conduct finite element analyses of these cartilage models and compare it with elastic foundation. But for now, the elastic foundation is just a lot more computationally efficient. And just a brief overview of why we're doing this kind of cartilage extrusion from the bone is so that in the future, we're not enforcing some sort of joint geometry that's actually not patient specific. So here you could see if we're just assuming from the literature that all joints have all humeral heads have a certain radius of curvature and all glenoids have a certain radius of curvature, that's not really representing these, for example, osteoarthritic subjects. And the MRI segmentation of the cartilage would of course be much more detailed, but we don't have access to the images of this data set. And the segmentation is also time intensive, and therefore we basically developed a method to make it more patient specific without actually having the patient scan data. And then we wanted to make the patient-specific model that also included patient-specific bone anatomy and muscles. So we've basically gone from a 3 degree of freedom glenohumeral joint based on the OpenSim model by Seth et al. We developed an automatic patient modeling pipeline, and then we have a digital twin of one of these biplane subjects with a 6 degree of freedom contact-based glenohumeral joint. So briefly, we import the scapula and humerus bones in the resting position. So this is a big difference, I think, to many current patient-specific modeling pipelines. So patient specificity kind of has different degrees. You can go from just very simple linear scaling. More recently, statistical shape models have gained a lot of traction because they can much better represent more complex changes in shape. But here we actually take the subject-specific bones and we don't morph the bones at all. We just replace the entire scapula and humeral bone in the model with the patient-specific bones. So that gives a very high degree of accuracy to the anatomy without having to worry about whether that patient's joint geometry is, for example, represented by our statistical shape model. And then we infer the clavicle and thorax positions from skin markers. We scale the thorax just with a very simplified affine scaling algorithm. We transfer the rest of the bones, so the lower arm bones, we just scale, but we don't have those patient-specific. And then we update the muscle parameters on a per muscle basis instead of just scaling them all. So we check the same resting position in the template model and the target model. And then we update the muscle parameters, so tendon slack length and optimal fiber length based on this. Right now, we're not doing any optimization of those parameters because we wanted to see whether this would work without tuning those parameters. And then we scale the segment masses based on the differences in the bone volumes. So to test whether this pipeline worked, we just used one subject for now, although the pipeline is automated. This is just for our initial test. This was just selected as first subject in the data set. We drive the model with the muscles, with the ground truth motion data being the biplane marker data. So this is not skin marker data except for the thorax. It's just markers that were placed on the biplane bone. So it's really the high resolution biplane kinematics. And then for this example, we drove the scapula non-dynamically, so we just prescribed the scapular kinematics, although we've also done some work on patient-specific scapulothoracic ellipsoid joint modeling, and that also looked quite promising. But for now, we just focus on the glenohumeral joint and muscles. So there we drive the scapula in the way that we know exactly how the scapula moved, and it's replicated in the model, and then the humerus must be moved by the muscles. So the main question was, can the muscles actively stabilize this joint center rotation to to the amount seen in the subject in vivo in this automatically generated digital twin with very wide passive bounds in the translations. And the answer is yes, we're getting quite promising results. It's still translating a little bit more, so about 1 millimeter more inferiorly and posteriorly. But here you can see, like in green are the large passive bounds, and then in turquoise is the tracking target, and then in orange is the subject. And then you can also see the traces of various markers, so on the distal humerus and various other anatomical markers in the little video. So the tracking is working quite well in this automatically generated model. If we look at the muscle activations, I just want to say the caveat is that we're still working on these models and the muscles are very simplified, and I would not take these calculated muscle activations as ground truth of this is the best the model can do, because I think this is very much a work in progress, but I still think I wanted to show this preliminary data because I think it's interesting to discuss. And we do see variation in the 3 degree of freedom joint versus the 6 degree of freedom joint as expected. That changes the muscle activation. So in the 6 degree of freedom joint, the rotator cuff is activated more, but interestingly also the deltoid. And we have some unusual, I would say non-physiologically looking oscillations here, which is why I'm saying this is a work in progress, and I'm happy to discuss that at the end if we have time. We do see also quite an extensive amount of patient variability in EMG data here on the right, and there's also always limitations to EMG data, but I think these qualitative comparisons, at least in general, of the timing of activations and the general profiles can be quite useful. There's also been other studies that have shown that if you have a 3 degree of freedom joint with or without the glenohumeral force constraint, you also get higher joint forces if you have this force constraint, which makes a lot of sense because instead of the simulation joint stabilizing the translations, the stabilization is coming from the rotator cuff, which will always be pulling into the joint. So the next step would be to refine the cartilage contact and adding a separate labrum, because we also think that that adds a little bit of stability. As I said, there's a lot of work to be done on the muscle adjustments. So right now they're very simplified in the original template model, and there are also some issues we've run into with passive stiffness in the deltoid being too high in the template model. So this is something that I really want to focus on in the next months to further develop the template model and even test different template models to really make sure that these muscle activations are as realistic as possible, and that also the muscle lines of action and wrap objects work throughout a range of motions, especially in terms of internal-external rotation, which can cause some issues with deltoid wrapping in most models. So that's something that I'm really interested in looking into. And then, of course, even though this subject-specific model was generated automatically, we want to make sure that we didn't just have a success by chance, so we want to test all of the other subjects and motions as well to make sure that this pipeline actually works for all of the subjects. So I've looked at it kind of in a static posture, and all of the muscle wrapping, etc., looks good, but we of course want to test in the dynamics. And then the next step is combine multibody dynamics and finite element modeling of the joint. So here's a little preview of that. That was still with a 3 degree of freedom joint, but we can show that we can dynamically couple muscle-driven simulations with finite element components, which I think is very interesting for investigating, especially things like bone stresses around the implant during dynamic motions instead of just at isolated time points. So to conclude, this digital twin generation pipeline enables us to really incorporate the subject-specific bones and joint geometry, and it's able to track quite well that subject-specific kinematic trajectories from the biplane. And all of this is happening through muscular stabilization because we really expanded the translational bounds of this model from not allowing any translations to having very, very wide translations. And therefore, these models will also be capable of modeling subluxation. So I haven't tested this, but if I've seen it in some simulations where something was off in the simulation and then the joint becomes unstable and subluxes, so it has that capacity. And also if we were to target specific muscles and turn them off and overactivate others, then it would also sublux. So this is encouraging for investigating instability cases with this model. So the overall takeaways I would say from this talk are that, first of all, healthy subjects vary in the joint kinematics, both in magnitude and pattern, but we were unfortunately not able to predict this from the bony anatomy or the posture, but I think there's still many other things that warrant investigation in terms of possible predictors of the kinematics. And we can use this translation data to benchmark biomechanical models, which I think is very interesting, especially from the translation side, because I think until recently, we haven't really had this very high resolution translational data. So kind of guessing what's happening on the joint level was always a bit unclear. And now we can really feed these as targets to the model and check, okay, is our model with these muscles, with these passive constraints, able to track this data? So it's a sort of kinematic validation, because we do feed it the targets, but if the model is unable to follow the targets, we know there's something wrong in the model. And then the simulation of the different degrees of freedom and joint limits, this affects the muscle forces. Next, we want to check the effect of these translations on the joint loading and the bone stresses. So that becomes very relevant for our implant project. And we really want to incorporate this patient variability for personalized medicine. So if we're testing different implants, we kind of want to go through a regime of different translations. Of course, we're hoping to collect more biplane data from pathological individuals that are undergoing these sorts of surgeries, so we have an even better idea what their joint kinematics looks like. And then we're also incorporating other factors that vary between subjects. So we've done a study on bone density variation. We also know that varies with sex and age as well. So we're also incorporating mapping these material properties into our finite element models. And our main question is really, is the optimal treatment patient dependent? So we want to put all of these patient specific parameters in the models, and then we say, okay, actually great, this implant A is always superior to implant B in all subjects, but we will never know that unless we're first able to model subject specificity in our models. All right, thank you very much.
Okay, so let's thank Eva for the great presentation, and we have time for questions. Feel free to jump in. So I can start with one. Oh yeah, sorry. Okay, some congratulations on the chat. In the meantime, I'm gonna ask you. So have you used how have you used your digital twin model in the clinical setting?
So we are still working on actually applying to the clinical setting, because I think I quite underestimated the work that would go into the patient-specific modeling. Like, first of all, just automating everything, and because we are really swapping out all of the bones, and then there's just a lot of technical things that needed to be solved there. And then the other part is, the cartilage modeling, basically using all these things to be able to validate the healthy models against the healthy subjects, so that we can then use the pipeline for investigating the implant. So that's something that we're starting to work on, but it's definitely taken a lot longer to develop the model to the point where we're happy to use it for clinical investigations. And as I said, there's still some work to be done anyway on the muscle modeling side of things as well. Yeah, so I'm always talking to the clinician about possible applications, and we have a lot of very specific things we want to test, but the model just hasn't been used for that yet. Like, I'm really starting the work on that currently. So making the implant models, incorporating those, yeah. But the idea would be that it's kind of twofold, so you could use it for development of novel treatments, so that could be implants, but that could also be osteotomies or anything like this, or also for personalized, more like preoperative planning. So which implant do you use? How do you position it? It could also give insights into that. Yeah, and we're working with a company at the moment who's having us also test several of their implants in our biomechanical models in the next months to see, to make sure that it holds across a couple of individuals in terms of anatomy and kinematics.
Would even add the rehabilitation, because it might be that you can, just adjust if the simulations are, working very well, then you can also adjust different types of rehab right away without yeah, so even short term, not really long term, maybe.
Absolutely, yeah, and I think that's a really interesting avenue of research too, is investigating, okay, what happens if I just increase the strength of this muscle, or just increase the, like, force the model to increase the recruitment, because maybe someone just needs some neurological training to recruit that muscle more. There, I think there's a lot of opportunity for that side of things as well. But I think there, I would even more so than the implant loaded, because for the implants, we just want to make sure that these are kind of feasible combinations of muscle activations that then result in feasible joint loading. But I think once you're starting to really look at targeted muscle training, then I would want even more confidence in the muscles. And I think there, it would also be interesting to test, okay, what if you have a super, super detailed model with, fiber embedded finite element muscles? How does that perform compared to these very simplified strand models? Is there a sweet spot in terms of, computational efficiency versus realism? So I think in terms of rehabilitation, I think there wouldn't be a lot more work needed in this, but it's definitely possible. And I definitely see it going that way as well.
Actually, building on your comment, I remember probably several years ago, there were soccer players that are having injuries all the time at the knees, not the shoulder, mostly the knees. But one of the philosophy was to strengthen, making the muscle as big as possible, like the quads and the hamstring as big as possible. And figured out that some soccer players ended up getting injured again quite rapidly. So I guess it connected a bit with your comment. I don't know if it is true because I don't have the statistics, but the people were talking about that, so it might connect a little bit with what you just said.
I think there's been some work also on gait retraining, like for knee osteoarthritis and knee pain. And I think it's mostly simulation work right now, but it seems to be at least an interesting avenue to explore. Yeah.
Beautiful. Other questions?
Thanks again, Eva, for your presentation. I think it was around slide 30 that you mentioned something about stability ratio. I wanted to ask if you have looked on this parameter as well, and how did you define this ratio, if so?
Yeah, so I am currently not implementing it, but I have tried to sorry, let me go back first. Yeah, so you're talking about this these force bounds, right, derived from the stability ratio. I think also that reference should have maybe been Dickerson and al, but he was in collaboration with Benedict Zagel. So they also used RDSynth, and I've tried implementing their code, but I haven't gotten it to work for a moving scapula, but it should be possible. But I think I see it as an either or, like you either have the stability ratios or you have the force targets. Of course, if I don't have any translation targets, right now I'm making the models that have the subject-specific tracking data from the biplane. But if you have a new patient and you don't know what their translations are, then of course you need to move towards some more predictive simulation or some sort of goal and say, okay, I don't know how it translates. Maybe I let that be defined by the contact geometry, but to really tell the model, like if we know it's a healthy individual, we do need to somehow prompt the model to, recruit the muscles, right? And if we don't have a specific translational target, then I think I would go more into this direction. But then, these stability ratios, they're so dependent probably on the individual subject anatomy. If you have a really flat glenoid, you're going to have like way less translational force it can withstand before it subluxes. So that's basically the stability ratio, right? It's the translational force relative to compressive force for the joint to sublux. Yeah. But there could be maybe the opportunity to run like some joint only without muscle finite element simulations for that given geometry of joint for the stability ratios, right? And then just see like where, the humerus starts accelerating, so essentially subluxing, and then incorporating that back into the muscle driven model. Or maybe just having some sort of, I've thought about this as well, like some sort of bound on the actual acceleration of the humeral head center. So if it suddenly starts moving, right, then it's like if it starts moving a lot, then it's subluxing. And then you could say, okay, if I know the subject is healthy and I want to model the healthy recruitment, then have that kind of as like an additional constraint in the simulation, right? So say, okay, our goal is to perform this movement, but if this happens, then recruit the muscles to make sure it's kind of restored back into the humeral head center.
Okay, great. Thanks. And you mentioned that's somehow software-related question about Artisan. I was interested that you mentioned something about morphing for personalization of the models. Is Artisans able to morph the bones based on STL data from CT, for example, or
there's some affine morphing algorithms in it. Yeah, but I use it for the thorax data the thorax is very rough, like mostly for just the lat attachment points and for the visualization, but it's also just a static thorax and rib cage, very simplified model from OpenSim. So we're morphing it to the biplane skin markers, but there's so much the spine isn't able to bend. It's very, like, we're doing some, affine morphing, but it's very rudimentary, but that's not our main focus. It's just to get an overall, visualization and some general muscle attachments. We're way more focused on the glenohumeral joint, which is why we replace the bones there. Yeah, but there's not really as an OpenSim kind of I would say a module where you just say these are my points, now morph it, make it subject specific. I think you can do it in the code, but I think there are tools to do it, but I replace the bones of interest. Yeah.
Okay, great. Thanks. And last question, when can we cite your translation study? Because I'm writing a paper right now, and that would be great. I don't know. Is there any plan that your paper is out? Then I can cite
the translations paper.
The first part of your presentation.
Yeah, we're hoping to submit it hopefully in this or next week. It's finished, but there's some kind of just debate of whether we want to shorten it and make it more clinical audience focused, or keep it as long as I've written it and make it more general biomechanics focused and what journal to target. So I think but yeah, if it's helpful for you to have the balance data, I'm also happy to share those numbers you were asking, the ranges, and I'll let you know once it's out.
Great.
Yeah.
Thanks. Thank you again.
Yeah, thanks for your interest.
Other questions? So before closing, I want to remind people that if interested, we're going to have a next speaker this week, actually Thursday, the same time, with the same WebEx room. And Professor James Wickling is going to be talking about muscle design for optimal performance. So you're of course welcome to join Thursday as well. So is there any last minute question for Eva? Well, if not, let's thank Eva for the great presentation. Thank you very much. It was a great pleasure. And thank you for the interesting talk.
Thank you so much for the invitation to speak. And thank you everyone for your questions and nice comments.
My pleasure.
It's really a pleasure. Thank you.
Thank you.